Hit the subscribe button or visit us at auau.auanet.org.
Good evening, and welcome to the Global Advancements in Prostate Cancer, the Role of Genetic Testing and PARP Inhibitors in Advanced Prostate Cancer course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Thank you to the course director, Dr. Todd Morgan, for planning an excellent education course. We thank you for your dedication and commitment to urologic education. Thank you as well to our faculty for their time, talent, and expertise in developing today's program. The AUA is accredited by the ACCME and designates this activity for a maximum of 1 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA University immediately following the live program today. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. Please visit auau.auanet.org to complete your evaluations and credit claim. Please stay tuned for a keyword that will be provided during the activity. The keyword is used to verify your participation in the activity. You will need to use this keyword to access the course evaluation, CME credit claim, and certificate. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit auau.auanet.org to view faculty, education council, and COI review work group disclosures. The AUA would like to thank AstraZeneca, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Merck for providing independent educational grants in support of this activity. This activity is meant to be educational in nature and in some instances reflects the opinion of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. We hope that you will actively participate as you connect and learn from each other during the course. Due to the size of the audience, all participants will be in listen-only mode without video, but we encourage you to ask questions at any time through the Q&A pane and communicate with one another through the chat box in Zoom. Please engage in today's program by submitting questions addressed to our expert faculty. Questions should be submitted through the Q&A box in your Zoom window. Questions will be addressed throughout the time as time permits and at the end of the program. Finally, I'd like to extend a special thank you to our course director, Dr. Todd Morgan, for his time, talent, and expertise in developing this program and keeping it relevant with the many advances. Dr. Morgan is a urological surgeon and a chief of urologic oncology at Michigan Medicine. In addition to being a clinician and surgeon, he is a translational surgeon scientist and is the principal investigator of 2 large randomized controlled trials evaluating tissue-based biomarkers in men with localized prostate cancer. Thank you as well to our distinguished faculty for participating in the course. I will now turn the program over to Dr. Morgan, who will introduce our faculty and lead us into our knowledge assessment.
Awesome. Thank you, Kaylee. And thank you everybody who's joining us live, and thank you in advance, potentially a while in advance, to those who are listening on the podcast. So yeah, before we begin, and by the way, we've got just a great course and an absolutely incredible set of faculty. So thank you. Thank you to all of you who are the faculty, and we'll introduce you guys in a sec. But before we begin, we would like to ask you to participate in this brief knowledge assessment. At the close of today's discussion, we will have a follow-up assessment using these same questions, and the results of these assessments help the AUA measure the educational effectiveness of this live educational activity and aid in the successful planning and development of future activities. So here's number 1. When counseling patients about the possibility of performing germline genetic testing, which of the following topics does not need to be discussed prior to ordering the test? A, risk of additional cancers. B, federal laws pertaining to genetic discrimination. C, cascade testing of family members. D, potential test results. And E, costs of testing. And we'll leave this up here for a little bit. Please pick one. This is where I wish we had some soft music.
Give a few more seconds for everyone to submit their response. All right, we'll move on to the next one.
All right, question number 2. Which of the following statements is false regarding genetic testing of prostate cancer patients? A, criteria for consideration of genetic testing includes family history of breast, ovarian, pancreatic, and colon cancer. B, testing can be performed with blood or sputum or saliva. C, multi-gene panel testing is covered by some commercial insurance providers. And D, when somatic tumor testing has been performed, germline testing is unnecessary.
A few more seconds to submit your responses, everyone.
Okay, number 3. Which of the following are the most common side effects associated with PARP inhibitor therapy? A, confusion and seizures. B, hypocalcemia and dyspnea. C, anemia and fatigue. D, hypertension and hypokalemia. And E, systemic allergic reaction, hypotension and syncope.
A few more seconds, everyone.
All right, number 4. A 71-year-old has mCRPC and recently progressed on enzalutamide. PARP inhibition is likely most effective in the setting of which of the following germline or somatic mutations? A, BRCA2, B, MSH2, C, HOXB13, or D, CHEK2.
Another second or two.
All right, and the last one, number 5. A 65-year-old male with a germline BRCA2 mutation underwent primary RT and ADT, and then subsequent abiraterone for disease recurrence. He now has multiple bone mets and retroperitoneal lymphadenopathy, and PSA is 15. Which of the following treatment options would be concordant with AUA guidelines? A, pembrolizumab, B, olaparib, C, enzalutamide, or D, radium-223. I've been known to have my kids supply me with bad jokes for these interludes, but I think I forgot. I can never remember them. So I saved y'all.
Another second or two. Okay, great. That concludes our knowledge assessment.
All right, let me make sure I got control. I've got control. Perfect. Oops, do I have control? Click to start remote control. There we go. I got it. So, all right. So this is the intro. This course will address the latest developments in advanced prostate cancer with a focus on approach to genetic testing, how DNA damage repair mutations lead to prostate carcinogenesis, PARP inhibition, and targeting DNA repair deficient tumors, clinical trials, and AUA clinical guideline recommendations. Here are the learning objectives. So after participating in this educational series, participants will be able to 1, review recommended criteria for genetic testing of prostate cancer patients, explain how to counsel patients about genetic testing and how to order and interpret these tests. 2, explain how mutations in DNA damage repair genes can lead to the development of aggressive prostate cancer and the implications for treatment decisions. 3, describe the role of the enzyme PARP in carcinogenesis, as well as the mechanism of PARP inhibition for cancer treatment. And 4, discuss clinical trial data assessing the efficacy of PARP inhibitors in advanced prostate cancer, including patient populations and clinical outcomes for each trial. All right, so now we got through all that stuff. We get to get started, and I get to introduce the faculty who are, like I said, they're, I mean, really, really amazing. First, and you guys can come on, and we can unmute your video. Dr. Maria Carlo is a medical oncologist at Memorial Sloan Kettering Cancer Center, where she cares for patients with advanced genitourinary cancers. She is truly a world-class expert in prostate cancer genetics and genetic counseling. We are really, really lucky and we're very grateful to have you here with us tonight. Next, Dr. Elizabeth Heath. She's a medical oncologist and leads the prostate cancer research team and genitourinary oncology multidisciplinary team at the Karmanos Cancer Institute. She's also the associate director for translational science. She is just down I-94 from me, and we share tons of patients and many research collaborations. And so I get to see firsthand just really how amazing she is in every way. And, you know, really can't thank you enough for joining us. Both of you guys coming to an AUA program, thank you so much. And last is Dr. Brian Helfand. He's a urologist and director of the prostate cancer program at the John and Carol Walter Center for Urological Health at North Shore University. Dr. Helfand is also director of the urologic division in the personalized program for cancer care at North Shore. Brian's really a leader in our field in prostate cancer, in cancer genetics, and really looking forward to getting to talk to you more in this program. And I don't know if maybe your video is not working, but I can't see it. Hopefully we can, there you are, beautiful. And so one more caveat just before we get started, just we're all colleagues and we know each other well, so we decided we'll get to call each other by each other's first names to keep this informal. But you know, incredible amount of respect for everybody here on this panel, so thank you again. All right, so now we get to segment one. We have 4 segments, and again, it's already been mentioned, but to the audience here tonight, please send in questions. We will try to answer them. We'll probably talk about some of them, and some of them we can answer directly in the Q&A box. So the first segment of this is on DNA damage repair mutations. And we're gonna have some cases to get us started off, and this is the first one. This is a 50-year-old man found to have a PSA of 125 nanograms per deciliter on routine screening. CT and bone scan revealed multiple bone lesions confirmed on biopsy to be metastatic prostate cancer. And see his family history: father died of pancreatic cancer at 55, paternal grandmother died of ovarian cancer, and germline and somatic testing were ordered. And here, you know, we have a germline BRCA2 mutation. And so that kind of frames the discussion somewhat and gives us something to think about as we talk about some of the deep science behind all this, because ultimately the deep science is part of what we want to understand. And so first I want to turn to Maria and say, you know, and we've got a slide here to help you out with this. How does DNA repair work in normal cells? I mean, help you out. I mean, this is your slide that you made to help, so that you can use to help make the explanation.
Great. Thank you, Todd. So our normal cells have DNA damage occurring all the time. Some of the damage is caused by obvious factors like carcinogens, radiation, chemotherapeutic agents, UV light, but probably most of the damage is actually caused by random replication errors. Cells have multiple mechanisms by which they repair these normal DNA damage that can occur. Broadly speaking, DNA damage can occur in 2 ways. So you can, a DNA strand, you can break one single strand, and that has a host of proteins that help repair that, or you can break both strands, the so-called double-stranded break. When we talk about PARP inhibitors, so the protein PARP actually works by helping repair single-stranded breaks. But double-stranded breaks have 2 main mechanisms. So one is homologous recombination, and there's a whole sort of proteins, including BRCA1, BRCA2, and others that help repair double-stranded breaks, essentially by using the other strand as a template. And this actually leads to pretty high fidelity repair, where there's fewer errors introduced when you repair that damage. You also have non-homologous end joining, in which, like the name implies, you kind of stick both ends together. I mean, it's a little bit more sophisticated than that, but essentially you're sticking both ends together. And this does lead to more errors when you're fixing the repair. So broadly speaking, this is occurring in our cells all the time.
And so, I mean, Maria, so just kind of to come back to this patient, right? So this is a patient with a BRCA2 mutation. Do you, we've got, when you think about homologous recombination, non-homologous recombination, where these a patient with different mutations falls,
Right.
does that impact you clinically?
Yes, it does. So if you have a germline BRCA2 mutation like our patient, so BRCA2 is a tumor suppressor gene. So if you have two normal, if you don't have a germline mutation, you have two normal copies that you start out with. And if you have a random mutation in one BRCA2 gene, you have the other allele, and that kind of takes care of most of it. And you can, have fine repair with one working gene. But people with germline mutations like this gentleman, a germline mutation in BRCA2, if a second mutation occurs in the other BRCA2 gene just by chance, they're left with no BRCA2. And that leads to a big problem in repairing double-stranded breaks. And that if you have a lot of double-stranded breaks, most cells can die after that, but some cells actually, gain advantages in replication, and that can lead to carcinogenesis. So that's in part why patients with germline BRCA2 mutations are prone to many types of cancers, including prostate, breast, ovarian, and pancreas.
Awesome. Right. So then I wanted to kind of turn to Brian. So you started to allude to this, that, right, so a patient like this has a germline mutation. That's in its own is not necessarily enough to cause cancer. And so a patient can start out with that and then also have a different mutation. They can have somatic, just only somatic mutations. Brian, can you talk about the difference between germline and somatic mutations?
Sure. So again, these are processes that occur in all cells that were kind of just described in healthy cells and in mutated cells. Certainly, this can all be messed up when you have these type of mutations. And I think everyone's familiar with BRCA1, 2 mutations that were just described. But those type of mutations or variations in the DNA can occur within the DNA that you're born with, things that were called germline DNA mutations. And that's the kind of mutation that's passed from generation to generation that is inherited. And that's really why it's really important to start asking family history information to kind of capture the likelihood of having one of those germline DNA mutations. Alternatively, there are somatic mutations. So these are mutations that occur strictly within tumor cells. And these really occur as tumors divide and start accumulating genetic defects that can lead to mutations in many of these genes. These are not passed on from generation to generation.
Right. And so, when we're going to really dig into this in a deep way as we go on, but I think that you guys have both made this really key point that there's a population of patients that are predisposed to having cancer because they've got a germline mutation, same BRCA2, but that in and of itself doesn't mean that they're going to develop cancer, right? So as you guys both were alluding to in that scenario, it takes that second hit versus a patient who doesn't have any predisposition but still can develop mutations, say in BRCA2, that are somatic, not inherited. And that's really important when we talk about family members, and we'll get into that. And so, thank you guys for covering some of that science. I'm going to just advance now to segment 2, and this is where it starts to I think get really clinically relevant. We think about patient selection and approach to genetic testing. So these are really thinking about the patients that are in our clinic that we see. So a patient like this, a 62-year-old African-American male, history of de novo MCS PC, castrate-sensitive prostate cancer that's metastatic, diagnosed 3 years ago. Initial presentation of bone mets and PSA level of 249, confirmed with a bone biopsy. You can see the past medical history here. He's got a family history of prostate cancer. Was on ADT and ABI for 3 years, and then upon disease progression in the bone, he was treated with docetaxel. Received 9 cycles of docetaxel with progression in bone and also liver mets. And biopsy of liver showed adenocarcinoma without neuroendocrine features. PSA was 450. And then he got germline and somatic testing that were ordered. And sure enough, it showed it was found to have a germline ATM mutation. So I'm going to bring in Elizabeth here finally. So this is because this is really key, right? there was a decision, and I can see in the chat, there was a question like, how do we make this decision to get germline or somatic testing? So why did we order germline testing in this patient? What's the justification?
Yeah, that's something that I think plagues all of us in our practice. You know, sometimes you're almost caught off guard because you haven't been thinking about it, and oh no, the patient progressed and now it's an emergency. And then you're like, oh boy, did I do it? Didn't I do it? And of course, if we're all, you know, charged with our lovely medical records, there's never one place to find it. So it's a struggle, but why we want to do it is to see if there are other treatment options available for patients. Understanding this pathway has really been a scientific advancement. You know, I think this paper in particular by Pritchard et al. In New England Journal in 2016 was a bit of a game changer. You know, I think everybody sort of thought this was the data, but then you look and you're like, oh my goodness, metastatic patients, 11.8%, you know, have germline DNA repair mutations. And you could see on that pie chart, we're talking about BRCA2, but there's a whole host of others. So it just speaks to Maria's explanation of how complicated this process is. And I think it's also important as we're thinking about testing about impact to family. Many of us are stuck maybe in institutions that don't have as many genetic counselors as we would like. I think everybody on the call probably would like to have more because it is a very tough situation. Most of the time, there is a way to get answers because we do know the impact of patients. And again, it's all about risk and understanding what that risk is. And a lot of patients that I explain that we're going to do this, they kind of hesitate until you realize, oh my goodness, this information might affect my children, my grandchildren. And I think that sort of impact to cascade testing can't be underscored, but we have experts in the field who are genetic counselors who can really understand that. So for the patient himself, I think it's important because it broadens potential treatment options. For the patient's family, perhaps this is a time to think outside of our individual patient and see how we can make an impact more broadly within the field of prostate cancer. You know, if we can identify folks at risk, we may do a better job.
Yeah, God, it was awesome. So tell me this, why do you think we were caught so off guard by this paper, by this team, right? I mean, in retrospect, we think, boy, that seems obvious. And of course, the greatest discoveries always seem obvious in retrospect. But you think about the last 20 years of our field.
I think we've always kind of put the bucket of genetic testing and BRCA into the breast and ovarian patients. Oh, of course, I've asked about the family history. You know, wait a minute, what does this have to do with prostate cancer? And I think it was a bit of a slow creep. You know, I think caught a lot of people going, I don't understand what's happening. And fortunately, we have colleagues in our field who sort of kept championing that message, you know, again and again, like, guys, we are missing an opportunity. Let's continue that. And that's where I think just even nationwide, it's been such a great opportunity for these sort of massive registries that can offer free testing and so on. I just think those are, you know, real important awareness things that we can share with our patients because everyone, you know, is whether you're in the US or outside of the US, this is something that is in a way a local problem because it really is dependent on access and, you know, insurance and all of that. So it's just more than testing.
For sure.
It's a mindset change, I think, Todd.
Yeah,
Todd,
for sure.
Todd, can I also, sorry to jump in.
No, I love
really
it.
Quickly,
Jump in.
is that, you know, one of the reasons why it was also underappreciated and why this was such a shock is that, you know, these type of mutations we really refer to as rare pathogenic mutations. They're rare in the general population. They're really 2 to 3% if you look at all of them, of all patients. So they're rare. Even if you look at the overall population of prostate cancer patients, we studied this for years and it was still very low. So when we specifically then had the ability to look at large cohorts as genetic testing also decreased in cost, we found that it was much higher. I mean, these are just germline. Again, that's the DNA you're passed on with, but it's another, you know, 10% with somatic mutations as well. So it's high. And I think that really explains why is that we were able to subset this and appreciate that these rare mutations were really enriched in guys with some of the worst disease we know of.
Yeah. Yeah, that makes a ton of sense. And so, and Elizabeth, you mentioned that. So now we understand that this is really important, and we recommend, we discuss genetic testing with so many patients, and yet we have this huge shortage of genetic counselors. And I know you guys must run into that same as we do, because in Michigan, in general, those visits with genetic counselors aren't reimbursable, which then further, creates that problem of not having enough genetic counselors. And so one approach that many of us take, right, is to have the clinician, the oncologist, the urologist do that pre-test counseling. And so I'd love to hear from Brian. How do you approach counseling and ordering of a test?
So, I think when you start talking to patients, you have to look at where that patient is in the kind of prostate cancer journey. And I think that that's going to influence when you start talking about obtaining this information, et cetera. And certainly I'm not going to go through the criteria, but prostate cancer is one of the most lenient in terms of insurance coverage for obtaining testing. Certainly most men who are newly diagnosed with kind of a grade group 2 or 3 or higher will actually qualify for testing, as well as family history data as well. Having said that, once we identify men who would qualify for genetic testing, then we really want to make sure that we go through the relevant information for them. Certainly, we bring up the implications in terms of, kind of legal implications. There was a act that was passed back in 2009 known as GINA, and this is the Genetic Information Non-Discrimination Act, which really prevented any employer from holding this information against a patient or holding it against them. So this has really been the standard. So a lot of patients will come in saying, hey, if I get this information, can this be used against me? The answer is no, and that's protected by law. Having said that, in a realistic real-time conversation, I do bring up that insurance companies, life insurance period, can still use this information and adjust rates based on that. They will also do the same based on family history information. So I do review that with them. I do review what the results would imply, meaning that if we find a pathogenic mutation, that's an obvious type of mutation or variation in a gene that has been shown to cause a disease, prostate cancer and or related cancers. We do review the possibility of finding what's called a variant of unknown significance, or VUS. Those results really mean saying, hey, this variation we believe to be likely benign, but it could be that in the future, these variations could be recategorized and be determined pathogenic. So it is something that we would update that patient. Often we will refer to genetic counseling to talk about pathogenic results. Often, even if you have a VUS, we will also refer to genetic counselors as a way to also counsel them in preparation, and also review the fact that most VUSs, about 90% of them, will ultimately remain or be categorized definitively as benign. We do, one last thing is, although not necessary at the time of testing, we do review the fact that if you did have a pathogenic mutation, what is the impact for family members and other type of cancers that the patient may be at risk for.
That was great. And so two things I want to really highlight about that. And so you just encapsulated in about 3 minutes, really the critical elements of counseling these patients. And if you've never thought about this before, yeah, a little more education is probably required before you start doing it, but it's doable. We can do it. But part B is, you can't just start doing genetic testing and like we're ordering a PSA. It's different. It's fundamentally different. You cannot just order okay, we're just going to send it out and we'll let the patient know the result. That's not good medical care. It's something that we really, really have to guard against. So it is, there are videos for patients to help with counseling, but we do have to provide them with this education, because once it's been ordered, there's no takebacks. And so thanks, Brian, for that explanation. So that's the germline. Oops, I just double advanced, I guess. There we go. That's the germline testing. But I want to talk a little bit more about somatic testing. And there was a question about, like, in the Q&A about the logistics of somatic testing. When do you do it? So Elizabeth, can you just walk us through briefly how somatic testing works?
Sure, and I think echoing, what we talked about, they're sort of looking at two different things. And in somatic testing, where this is all a little bit murky, is there's so many ways you can check. So a lot of us say, okay, well, we've kind of learned by tissue, and at least in this Robinson paper, it was really like, oh wow, what's the landscape somatically speaking? Do we have? And here the important part is that you can use tissue, you can test blood. A lot of different companies can do that, and of course, there's pluses and minuses with 1,000 caveats for all of these. You can also use archival tissue. If you're really, stuck and there's nothing in the metastatic arena where you can biopsy safely, or you tried and it didn't work. I think we don't often think about checking the original biopsy or the radical prostatectomy specimens, as long as it's not like 25 years ago, and it's somewhere within, a period of time that's reasonable and that you have access to. And I think here, somatically, 23% of the mutations are identified in the DNA repair pathway. So I think this was the other seminal paper for the attendees today. If you had to read a second paper, that sort of puts you in that space where you're wondering, how the heck did we get here? These showed all the different pathways that all of a sudden we recognize were either actionable or quite relevant to this discussion. In this sense, we don't fuss too much about the impact of family. This really is everything about the patient and what you can do. Of course, many of us have who have access to this use it sometimes to improve eligibility for clinical trials for novel agents. So there's a lot of ways that one could do it, but I think the general sort of recommendation is, yes, you need to try and test.
Yep. And so then again, when you send the tissue out, and again, this is to answer the question, it goes for DNA testing, right? So this is not, these are not RNA gene expression tests. This is looking at the DNA, looking for specific mutations, looking for changes that would tell us that gene is non-functional.
Yeah, and Todd, I think this is where it does get confusing. So not all tests are the same, not all platforms are the same. Here's my suggestion is, ask the person who's perhaps the expert in that particular company to make sure, are you looking at whole exome sequencing? Are you doing whole transcriptome sequencing? Are you just doing a limited gene set? Those kinds of things. Are you, kind of the details, so you have a better understanding? Because I think the other, and this is my pitch and plea for all of us in our community, is once you do this, you got to put it in the note. So what happens a lot is you're like, oh, I had some sort of testing. Nothing was that important, and you're not really sure what that means. So if possible, either include it or actually write down, when and what tissue and what platform you use, so that we can all inform one another in a more timely fashion.
That's an awesome suggestion. Really good. And you were kind enough to create this slide, kind of comparing germline and somatic testing. And to kind of keep us on time, I'm just going to leave this up here. And Brian also covered some of this, but I do, before we move to the next section, because you talked about different tissues that we can use. And of course, sometimes maybe they didn't have a prostatectomy, or the prostatectomy tissue isn't available, and they've got a bone metastasis, and that's really challenging to get viable tissue from. And so, Maria, what's the deal currently with circulating tumor DNA? Can we use that as a replacement?
You can in some cases. So circulating tumor DNA is essentially a test where they look at the fraction of circulating DNA that's cancer derived in the blood. So they take this DNA, it's also sometimes called cell-free because it's in the plasma, not in one of the lymphocytes or white blood cells that's circulating in the blood. So there's various pros and cons to testing ctDNA. You know, if it's still in the guidelines, and there's certainly a longer track of evidence for, as Elizabeth was mentioning, testing ideally the metastatic lesion if you have access to that first. But in many trials, like the ones that tested PARP inhibitors that we're going to talk about later, they use circulating tumor DNA was allowed as a method, as a ways of finding mutation. So some caveats to this is that there needs to be a higher disease burden to identify circulating tumor DNA. So somebody with a low tumor burden, you may find nothing, and it doesn't mean that there's not, you know, it may give you a false negative. There's also false positives. So there's clonal hematopoiesis in the blood. So you may have, for example, a mutation. So clonal hematopoiesis, unfortunately common process of aging is that you acquire mutations in your circulating cells, and sometimes these form clones, so you get a sometimes quite significant allele fraction in the blood, and this can be mistaken from coming from the tumor, but it's actually coming from the blood. So you wouldn't want to treat somebody thinking their tumor has, for example, an ATM mutation when it's really clonal hematopoiesis. Now, that being said, it is more non-invasive, right? It's a blood test. Sometimes you get the results quicker, right? Because you don't have to do a biopsy or extract DNA. And actually, some of these tests are FDA approved for the detection of DNA damage repair mutations if you're thinking of selecting therapies like olaparib, PARP inhibitor for patients.
Yeah, awesome. So are you using these tests?
Yeah, and so a good, you know, there's different practices even, you know, within the same institution. But one way we use them, for example, is if you can't get adequate metastatic tissue, and the prostatectomy was a long time ago, there's no issue. We certainly use these tests for treatment selection.
Yeah. Okay. That's great. Okay. Thank you so much. I'll keep us moving. That was really a great section, team. Thank you. So segment 3, we're going to talk about the PARP enzyme. We're going to talk about targeting DNA repair deficient tumors. The case is a 70-year-old. He's a university professor who has metastatic castration-resistant prostate cancer, who underwent treatment with multiple lines of therapy. Tumor was highly resistant, and had a bone biopsy and was found to have a BRCA2 mutation and started on olaparib, a PARP inhibitor, and had an excellent response. So here's what his PSA did, which is pretty remarkable in that setting. But a difficulty with fatigue and anemia, and so this is where I want to first turn back to Elizabeth and say, okay, can you just walk us through a little bit about the PARP enzyme so we understand what this is, because we're going to talk about targeting it.
Absolutely, and I think we keep seeing, the figure that this is a different figure, but Maria really explained this quite well. There's always repair going on because we're such complex human beings. There's damage that goes on, and the way we remain sort of healthy and moving forward is that we can sort of repair ourselves. And PARP, or polyadenosine diphosphate ribose, is that really important protein that can repair damage from a single cell break. So when you have a single strand break, using this base excision repair, you basically can, sort of fix the situation. And what happens with PARP inhibitors is they sort of stop these PARPs from doing their jobs. And then it sort of, in our next slide shows sort of what forces it. But it is important, I think, for our audience to know the different ways, because it comes up a lot on board exams, in case we have some trainees on there where you're having to sort of recall, what you learned in medical school, because who'd have thought we'd be worrying about this in the GU space, and here we are. But kind of putting together sort of like, okay, this part's supposed to help me with my single strand break. When you have a patient with HRD mutation, then you're sort of coming up on this concept of synthetic lethality in these BRCA mutated tumors. And these PARP inhibitors really prevent the repair. And again, it's this, the words that are coming out is sort of PARP trapping. So they're just trapping this inactivated PARP onto these single strand breaks. And then you're like, oh boy, I think this cell's in trouble. So now you have an increase in the double strand break of these replicating cells. So if it was sort of a normal cell, oh, good news, you have your route and there's your repair by homologous recombination. But if you don't, then you're basically in trouble, lots of DNA damage, and then we're in trouble. So I think this sort of complexity, it also shows, when we're thinking about drug development, Todd, there's other ways to target this, because the way to think about single strand breaks or double strand breaks just keeps evolving. Like, I'm fascinated with how really well studied this this area is. So I think there's more considerations for other areas that we could target to continue to try to sort of kill these cells. So
yeah, I mean, it's amazing to reflect back on like sophomore year of college biochemistry. I think that we were learning. This is what we were learning, and
yeah,
all of a sudden, how in the world is that so relevant to patient care? And so this concept of synthetic lethality that you explained it, again, I remember, learned that in probably like some random college class, and it doesn't mean much at the time, but this is, but it really means a lot, right? And so that's this point that normal cells do not respond in the same way to this drug as cancerous cells that are predisposed, that have a mutation that impairs double strand repair. And so it's remarkable. And I'm sure, I have no doubt, you're absolutely right about new ways of targeting this process, but also when you think about how cells develop resistance to these therapies, right? By all of a sudden, say, turning their BRCA active again, right? Another mutation that shifts it back in frame. And it tells us that our bodies are amazing, and we have a lot to learn, and a lot of ways we can hopefully do better than even what we're doing currently, which is amazing. I wanted to get Brian back in the game here, and just talk about side effects of PARP inhibition. It's really important to cover that.
Yeah, I mean, I think as a urologist, and certainly the practice I'm part of really refers a lot to medical oncology, but I'm still seeing these patients for urologic issues concomitantly, and certainly when we look at the trial data, it's not uncommon that we will see anemia or thrombocytopenia. And so that actually in some of the studies has been reported up to 50% of the time. And then I think, when any drug is being used, I think you can always have the possibility of having what I call more general side effects. And that's anywhere from, kind of GI side effects, nausea, diarrhea. I think fatigue is also very common. Most of these, you don't really have to stop the medications. In fact, most of them can kind of be observed if they're tolerable to patients. I do think if they become intolerable, or certainly blood levels become very low, sometimes they'll half dose, and we have our colleagues on the phone here who can probably comment even further, but it's rare that you totally have to stop the medications.
Yeah, thanks. And I'd love to hear Maria's input on this. So anemia and fatigue are the most common side effects. And I mean, how do you manage it? Do you change dose? What do we do?
Right. So for this, I'm kind of, so I follow the book. So I usually, we were fortunate in that we had some of the studies that led to approval of PARP inhibitors. So I usually go to the protocol of the study and I look at, what were the guides back then. So if certain blood levels are within this range, then that's the dose reduction. You can also give holidays and then restart. And these side effects do occur. Sometimes these drugs are given, much later on in the course of the disease, where the bone marrow is already, seen chemotherapy and others. So certainly, and they can occur quickly as well. So you have to keep a close eye, have them come back frequently, especially at the beginning, because you may be surprised with the degree of anemia or thrombocytopenia.
Sure. Okay. Thank you. Well, let's shift now to the fourth and final section. And this allows us to talk about patient outcomes, clinical trials, and current clinical guidelines, including a relatively recent AUA advanced prostate cancer guideline, which little bit biased, but I think it's quite good. And so here's the case, which is this one, a 67-year-old man, history of metastatic prostate cancer, diagnosed 3 years ago, biopsy-proven bone metastases, treatment with ADT and enzalutamide, and he developed MCRPC now with a rising PSA and increasing metastatic burden in the lung and bone. Germline and somatic testing were ordered and notable for a somatic BRCA1 deleterious mutation. All right, so this is, this is definitely this is a situation that we come across not infrequently, and we now have a remarkable amount of trial data to help us understand this. And so, Maria, can you walk us through some of these key trials and what are the key findings, how we interpret them?
Right, sure. So I think there are 4 key trials, essentially one with each PARP inhibitor that's currently FDA approved for different indications that have studied PARP inhibitors all in the metastatic castration-resistant setting. So the first 2 trials, Profound and Trident 2, have actually, based on the results, the drugs olaparib and rucaparib are FDA approved for men with CRPC. Profound is the only phase 3 trial, so it was actually comparing olaparib after progression on novel hormonal agents compared to physician's choice. And in that trial, it gets a tiny bit complicated in all the trials, essentially, because initially they allow for people with all sorts of mutations, but that they analyze, they sorted out by mutation BRCA1, 2, and ATM versus others. But essentially in the Profound trial, they found a significant improvement in progression-free survival and later on in overall survival in patients treated with olaparib. So that was FDA approved. Trident 2, single arm. The rest of the trials are single arm phase 2, but they also found an improved response rate in patients on the PARP inhibitor. Or not an improved response rate, because they weren't comparing technically to anybody, but a significant response rate of 44%, for example, for Trident 2, and a PSA response of 54%. So rucaparib was actually, the label was approved for patients in the efficacy population, which was only for BRCA1 and 2 alterations. Although other patients with other mutations were included, and there's actually, a nice analysis later on showing that, at least rucaparib, probably all PARP inhibitors seem to work better in patients with certain mutations. BRCA2 clearly, BRCA1 as well, probably not as well as BRCA2, but some others like ATM, really didn't see quite enough benefit. So that's important when you're counseling patients, because if you're treating a BRCA2 patient, you can quote pretty high levels of response. I'm more careful counseling, what is the likelihood of response in somebody with another mutation, which is much lower response. Again, that wasn't the primary endpoint of these studies, but post hoc analysis have shown.
So in this clinical scenario, the patient with a BRCA1 mutation, you wouldn't hesitate to recommend a PARP inhibitor.
Correct. Yes, we have, phase 3 and 2 data showing that in these patients there is a significant response. The BRCA1 mutations, there's just fewer of them. So if you look at, the study from Pritchard and all, the majority of these patients have BRCA2 and not BRCA1. So they're just smaller numbers.
Yeah. But there are a fair number of ATM mutations. So how do you interpret this data with respect to ATM?
Yeah, honestly, I think, there's pretty compelling data that PARP inhibitors are not that efficacious for, there are some responses in the trial if you look at the numbers, but I think there's definitely need for better therapies for ATM carriers. And I know there's a lot of ongoing trials with ATR inhibitors and other things to see if we can improve on responses.
Yeah. And then, so you got on this slide, right, Propel and Magnitude, presented at ASCO GU.
Yeah. We can talk like an hour about this, but
but okay, how about 60 seconds? But I'll get 9. I don't know, but yeah,
so,
it's really fascinating,
right,
and amazing to have those both presented at the same session.
Yes. So fresh off the press. So Propel and Magnitude are two phase 3 trials that were just presented in the 2022 GUS Genitourinary Symposium. Both were testing combination PARP inhibitor plus abiraterone in the first line setting in metastatic castration. Remember, the other trials were after progression of novel hormonal treatments. This is first line setting. So interestingly, Propel, which studied olaparib plus abiraterone versus abi alone, independent of DDR status, there appeared to be a radiographic progression-free survival improvement. So it was a positive trial in all comers. And there was a significant portion that didn't have a mutation in one of the DDR genes. Now, Magnitude, similar design, niraparib, another PARP inhibitor plus abiraterone compared to abi. Here, they also included a cohort of patients with certain mutations in DDR. They also included patients without mutations. The cohort of patients without DDR mutations was stopped early due to futility. So no improvement in that group, but there was an improvement in the DDR group. So, a little bit contradictory results. There's a lot of comments of why, could it be tried, not necessarily the drug, but could be trial design that led to that. There's still no overall survival improvement with any of these trials. So I think there is still much to learn about why this happened with when, if ever, there is a role for PARP plus abiraterone patients without DDR mutations.
Thanks. That was a great summary. I think we all want to see the published work, right? And
right.
We'll
There's also other trials that are still ongoing, which hopefully will also shed light on this.
Yeah. So we've got a couple minutes left for us to talk before we do the post-test questions, but I wanted to have a chance to talk about what guidelines exist. So Elizabeth, what we walk away and we're seeing our patients and we want to be able to reference some guidelines. What should we use?
Well, I think the good news is there's, like anything else in our business, there's a lot of guidelines. I think there are many centers that would default to NCCN, which does cite both olaparib and rucaparib, and of course the AUA Advanced Prostate Cancer Guideline is fabulous, absolutely fabulous, and should be looked at. But I am also cognizant that there are attendees on this webinar and future podcasts from outside of the US. So, where is that? So I think European guidelines are out there as well, from ESMO 2020, EAU 2021, and this will continue to evolve. We're not just US and European centric as well. I'm sure there are, other guidelines in Asia and other places around the globe. But I think the messaging should be, you won't know whether PARP inhibitors is even part of the story if you don't test. So one is, what are you going to do about testing and when? And that's starting all the way from local high-risk disease to metastatic, and then the type in terms of germline versus somatic. And I think all of that is important, probably as a first discussion before you recognize who's actually a candidate for a PARP inhibitor. But I think the guidelines with regards to olaparib and rucaparib for all of these should be within at least their currently approved setting. So we're not, advocating for something off-label.
Yep, absolutely. And then, as we think about kind of our turning towards the future, hopefully, we will have evidence that these drugs help patients earlier in disease and for a longer period of time. And Brian, can I ask you to just give me a little bit on where are we going? What's coming?
I mean, I think it's like most of the things in urology that we've seen is that, we always we start off at one end and we want to see where along the spectrum it really has its home in multiple potential places. So I think that there are ongoing trials right now that are moving toward even earlier stages. So certainly metastatic castrate-sensitive prostate cancer. There's some neoadjuvant trials that are, utilizing PARP inhibitors for both mutation carriers and non-carriers. Unfortunately, we still don't have these results, or we should have them hopefully soon, or at least some hint at some of their efficacy. But I do think that it's appropriate to start looking at this and seeing where these really kind of fit in and in what stage.
Yeah, awesome. And I cannot wait to start to see some of that data. I'm really hopeful about it. Well, I think I don't know, we have a minute. We have a minute for a question, which is this from Roberto Ochoa. In a patient with mCRPC previously treated with abiraterone who has a PALB2 mutation, is olaparib useful, Elizabeth?
Well, I think in terms of the study, the answer is yes, and certainly by indication as well. But it's the same thing that Maria mentioned, just setting expectations, recognizing that the response may not be as robust as one would hope, or if they had a BRCA2, but I certainly would prescribe olaparib for that patient.
You would for somebody with a PALB2 mutation?
Yeah.
Oh, that's good. That's a great question. Okay.
I
Maria,
agree
you
with that.
too?
And if you look at the number, PALB2 is rare, so you're not going to get great numbers of what the response rate is, but there were certainly responses in PALB2 carriers. And interestingly, if you do have a PALB2 mutation, there's a high chance it's germline. So looking at the split, and to me, patients who have a germline mutation are I think, if you can't do biallelic analysis, to me, they have like a slightly higher chance of the germline mutation driving the cancer as opposed to like a random somatic mutation. So,
Yeah.
so I also agree.
Wow. Okay. That's great information from both of you guys, and that's a great question. So I think I get to turn it back over to Kaylee, but before I do, let me just say thank you to the three of you. That was really, really great. Great to see you. All of your expertise is amazing, and it's so kind of you to share it.